Imagine you see a patient walking with a really distinct abnormal gait. Their toes are dragging, they keep tripping over their own feet, and their mobility is just severely compromised. It looks like one specific problem, right? But what if there are two completely different foot conditions that look almost exactly the same on the surface? In this explainer, we are breaking down the absolute critical differences between foot drop and foot equinus. Whether you're a patient, a physical therapist, a med student, or even a surgeon, understanding this stuff could literally save you from a devastating diagnostic mistake. So, what if two opposite conditions looked exactly the same? Just imagine the devastating consequences of confusing these two. We are talking about the fundamental difference between a nerve problem and a tendon problem. Getting this wrong? Well, it could lead a totally well-meaning surgeon to perform the entirely wrong operation. You could end up applying a permanent physical, mechanical fix to a condition that actually required a neurological treatment. Talk about leaving a patient worse off than when they started. So let's unpack exactly how we solve this mystery.
Section 1. Defining the suspects. Neurological versus mechanical.
Okay, our first suspect is foot drop. Now, this is primarily a neurological problem. It happens when the muscles responsible for lifting the foot upward simply become weak or completely paralyzed. Let's think about the actual mechanics of walking for a second. Normally, during the swing phase of your step, your ankle should dorsiflex. That's just a fancy medical term for the foot lifting upwards so your toes smoothly clear the ground. But with foot drop, that crucial upward lift completely fails. And because the foot just hangs downward, the toes drag on the ground. To compensate and avoid tripping, patients often develop what we call a steppage gait. They end up lifting their knees unusually high, almost like they're marching. To really wrap our heads around this, we have to look at where this weakness actually comes from. And the common causes here all point right back to the nervous system. We're talking about issues like a peroneal nerve injury. Think of it kind of like a frayed wire in your leg that just fails to tell those foot-lifting muscles to fire. It could also be caused by central nervous system issues, things like a stroke or multiple sclerosis. You also see it with lumbar radiculopathy, which is basically a pinched nerve in the lower back, or even severe conditions like ALS. The absolute biggest clue, the defining characteristic of foot drop, is pure neurological weakness in that ankle dorsiflexion. The signal from the brain to the muscles simply isn't arriving. Now, let's contrast that with our second suspect, foot equinus. Unlike the pure weakness we just talked about with foot drop, equinus is a mechanical or muscular restriction problem. The ankle simply cannot bend upward properly. And why is that? Because the calf muscles, or the Achilles tendon running down the back of the leg, are just excessively tight. It's a literal mechanical roadblock. Because of this extreme tightness, the heel lifts early during a step, or in severe cases, the heel might not even touch the ground at all. The patient ends up basically walking on their toes or the balls of their feet. And the causes for foot equinus? Totally different from our previous list. We might see a naturally tight Achilles tendon, or conditions like cerebral palsy, which can cause severe muscle spasticity. It can happen from long-term immobilization, too. Think about being stuck in a cast for months, where the tendon physically shortens up. We also see diabetes-related stiffness, muscle contractures, or even just habitual toe walking. The big key issue here is limited dorsiflexion due to physical tightness. The muscles aren't paralyzed at all. They're just physically restricted from moving.
So, here is the crucial point of contrast. Both of these conditions can create abnormal walking patterns. Both can cause toe dragging. Both profoundly change balance and gait mechanics, which is exactly why they confuse people so much at first glance. But their root causes are polar opposites. On one side, we have neurological weakness where the foot cannot lift. On the other side, we have mechanical tightness where the ankle cannot bend upward. Understanding that core difference changes absolutely everything about how we approach treating them.
Section 2. The danger of misdiagnosis. Just imagine performing a permanent tendon lengthening surgery on a patient whose real issue is actually nerve damage. Or, on the flip side, giving complex nerve-related treatments to someone whose Achilles tendon is just severely contracted. Applying a mechanical surgery to a neurological patient doesn't fix the weakness at all. It just adds a massive surgical trauma to an already struggling limb. This highlights exactly why treating the true root cause is absolutely 100% critical. Because if a medical professional gets this wrong, the cascade of failures is pretty devastating. We aren't just talking about a treatment slightly underperforming here. We are looking at outright failed surgery. The patient can be left with permanent gait problems, severe muscle imbalances that throw off their entire body mechanics, chronic pain, and a really tragic loss of mobility.
Proper assessment isn't just a best practice, it is absolutely vital before anyone even thinks about stepping into an operating room.
Section 3. Diagnosing the root cause. When a specialist suspects a neurological issue, they run through a very specific protocol. They'll thoroughly check muscle strength. They might conduct nerve conduction studies or perform EMG testing, which looks specifically at the electrical activity in the muscles, all alongside a comprehensive neurological examination. But here is the massive, undeniable clinical giveaway for foot drop. If the doctor takes the patient's foot in their hands, they can usually manually possibly push the ankle upward. The joint itself is totally free to move. The patient just lacks the neurological strength to do it themselves.
Now, what happens if we test for Equinus instead? Here, doctors evaluate Achilles tightness and check that passive ankle range of motion. They'll perform something called the Siffer-Skield test, which helps isolate whether the tightness is in the calf muscle or the Achilles tendon, and they will closely analyze the patient's gait mechanics. The critical difference? When the doctor tries to manually push that foot upward, they hit a literal wall. Physical tightness physically blocks that passive upward movement. The joint simply will not bend past a certain point. No way, no how.
Section 4. Targeted treatment solutions.
Notice how completely different these treatment paths are? I mean, they have to be because they're solving entirely different physiological puzzles. For foot drop, non-surgical treatments focus intensely on neurological support. If the brain signal can't lift the foot, we use ankle-foot orthoses, or AFOs, to physically brace it into a functional position. Or we use functional electrical stimulation, which is just incredible. It artificially triggers the nerve, essentially bypassing the brain's broken signal to fire the muscle directly. Surgically, doctors might perform a tendon transfer. This means they actually detach a completely different, healthy muscle and reroute it to do the job of the paralyzed one. But for foot equinus, the approach is purely mechanical. Non-surgical treatments involve aggressive stretching programs, serial casting to slowly and systematically force the shortened tendon to lengthen over weeks, or even targeted Botox injections to forcibly relax a spastic calf muscle. And surgically, they perform an Achilles tendon lengthening, where they make precise cuts to physically extend that tight, unyielding cord. This is exactly why identifying the root cause is the single most important step in the entire process. You simply cannot brace a tight tendon, and you cannot stretch a paralyzed nerve. Treating the root cause correctly dictates the entire path to recovery.
If you take away just one core piece of knowledge from this explainer today, let it be this golden rule. Foot drop is weakness. Equinus is tightness. It's a simple, elegant little mnemonic, but it cements the absolute most important takeaway. Accurate diagnosis always comes first. You have to know if you're fighting failing nerves or unyielding tendons.
It really makes you look at human movement in a whole new light, doesn't it? So I'll leave you with this final provocative thought. The next time you see someone trip or notice someone walking with a slightly unusual step, ask yourself, is it their nerves or is it their tendons? The hidden mechanics of human mobility are deeply fascinating, and as we've seen today, incredibly high stakes. Thanks so much for joining me to explore this complex medical mystery and keep questioning what's beneath the surface.